Good morning. Why don't we go ahead and get started? So on behalf of the Children's National Leadership, it is my great pleasure to welcome you to the 2019 Children's National Research and Education Week celebration. This is a vibrant exhibition of scholarly achievements by our faculty, staff, and trainees across a wide array of disciplines and focuses on the roles they play in advancing medical sciences, education, innovation, and providing the highest quality of care for children. This year's theme is Frontiers in Innovation, focusing on science-based discoveries across the broad spectrum from our dynamic and diverse community that is committed to achieving breakthrough outcomes and improving healthcare for children. We're excited to display over 350 projects that illustrate advances in the development of new therapies, methods, diagnostics, and devices. This year's event will include keynote presentations by this morning's speakers, Dr. Adnan Hyder, as well as Dr. Polly Joseph, Dr. Vanessa Carey, Dr. James Wilson, Dr. Margaret Clack, Dr. Stephen Thomas, and Dr. Stephen Rosenberg. We're honored that they'll all be joining us for this week's celebration of innovative research. Finally, I do want to make a special note of thanks to the Event Planning Committee and all the partners that developed this year's program. So before I introduce Dr. Hyder, I'd like to just give you a few quick announcements. The poster sessions are held from 1 to 3 p.m. today in the main atrium. As I mentioned, over the course of this week, over 350 posters will be displayed. All abstracts can be viewed in the ebook and PDF, which can be downloaded from the Research and Education website. For all events, please pick up a brochure that's located at the back of this auditorium. And finally, during these presentations, and specifically the question and answers, please wait for the microphone so we can pick you up on WebEx. And I guess that's not final. I did want to acknowledge that Dr. Craig Sable and the Global Health Institute and the CHI have a mix and mingle. It's 5 o'clock somewhere in the world that will follow this session in the research atrium. So now it's my great pleasure to introduce this morning's speaker, Dr. Adnan Hyder. He's the first speaker of our Research and Education Week. By way of brief biography, Dr. Hyder received his MD from the Aga Khan University in Pakistan. He then came to the U.S., where he received his MPH and PhD in public health from the Johns Hopkins University. He currently serves as Senior Associate Dean for Research and Professor of Global Health at the Milken Institute School of Public Health at the George Washington University. Previously, Dr. Hyder served as the Associate Chair of the Department of International Health and the Director of Health Systems Programs at the Johns Hopkins Bloomberg School of Public Health. At Hopkins, he was also the Associate Director for Global Programs at the Berman Institute of Bioethics and the founding director of the Johns Hopkins International Injury Research Unit. For over 20 years, Dr. Hyder has worked to improve global health in low and middle income countries across Africa, Asia, Latin America, and the Middle East. He has pioneered empirical work around health systems, ethics, and injury prevention in the developing world. His studies have focused on the epidemiologic burden, understanding risk factors, exploring potential innovations, estimating the economic impacts, and appreciating sociocultural differences, or correlates, of non-communicable diseases around the world. He studies health systems constraints and biomedical ethics, participated in training literally thousands of health professionals, defined the loss of healthy life years, and explored issues of health policy development. He's co-authored over 300 scientific peer-reviewed papers, numerous world reports on road safety, child injuries, and health systems. The title of his presentation this morning is Emerging and New Challenges to Child Health, a Global Perspective. Adnan, it's so nice to have you here at Children's, and welcome to Research Education Week.
Thank you very much, Dr. Lisa K. Woodford. I'm delighted and honored to be here. I joined the GW family only 6 months ago. So this is quite a bit of an introduction to your lovely hospital, which I've heard about, of course, for many, many years. Dr. Batchor, thank you very much for attending. And to those of my colleagues from Children's National, thank you for taking the time out. Hopefully there are children still being treated and served in your hospital by other colleagues. So today what I'm going to do is talk to you a little bit about my perspectives on the emerging and new challenges in child health. I will throw a lot of information at you. I'm going to throw both data, but also concepts. And so it's important for you to remember I'm going to take you through some data slides. Then I'll tell you what I think are some of the challenges for child health. And then I'll tell you some potential pathways for addressing those challenges. Because I don't believe just in diagnosing problems, but also in solving them. And that's the perspective that I will have. Throughout this talk, I recognize the value and the experience that you all bring to the table. So right at the front, I'm going to say that this is influenced by my perspectives, which are global in nature. It's influenced by the things that I've studied and done and worked on, but also I'm generalizing. So there are some assumptions that I'm using in this talk. And of course, for every assumption, there's an exception, and for every generalization, there's an exception. And I'd be happy to dialogue and debate about them in due course, particularly at the end. So with that, let's dive in and talk a little bit about the global burden of disease for children. And in this particular talk, I'm going to refer to the GBD, or Global Burden of Disease data, for the Institute for Health Metrics and Evaluation. For those of you who are familiar with it, this will be not new knowledge. And for those of you who are not, I'm happy to talk about that data at some point later. So this slide basically demonstrates the global death rates for 0 to 19 years. You'll ask why 19? Because UNICEF defines children as anyone below the age of 18. That's because GBD cannot generate easy data below 18. So that's why we use the cutoff of 19. We can discuss that separately. And two things are important. First, children, unfortunately, succumb to death everywhere in the world, whether you're high income, middle income, or low income. But secondly, you see that the darker the color, which means the higher the rate. So there's a concentration of high rate areas that we can define, both in sub-Saharan Africa as well as in South Asia. Similarly, if you look at the change that's happened in child death over time, particularly if you look at the leading conditions between 1990 and 2017, you begin to see, first of all, that overall rates have come down. And since you can't actually read the slide here, there are specific causes that have actually emerged. And you'll see things like self-harm and violence coming into the top 10 causes of death. That was never the case 30 years ago. And we can talk about whether that's a real change or whether that's a data issue. We can come back to that later. Now, if we take these deaths and convert them into years of life lost, I'm happy to explain that in a separate lecture on how you take deaths and convert them into years of life lost. But you also look at the causes of those years of life lost, you get a picture like this. From the left to the right are the age groups from neonatal all the way to 95 plus. And the red are generally infectious, maternal, and communicable conditions. The blues are non-communicable conditions, and the greens are injuries, trauma, and violence. And if we look at the first 18 years of life, what you begin to see very clearly is a movement as you go from the left to the right of the reds flowing in to the greens and the blues, which means that over the period of time that you all look after those kids, there is a change across the ages, and I know you're familiar with that from a clinical perspective. Actually, if you counter and adjust for disability, in addition to mortality, the picture remains very much the same. This is exactly the same, except it's counting disability-adjusted life years. And again, we can get into the pros and cons of DALIs, etc. But for now, assuming that it's a somewhat decent indicator, this demonstrates again that even when you adjust for morbidity, you have that transition from the red to the blues and greens across the 18-year lifespan. However, the world in general, particularly the United Nations, has generally focused on the under 5. UNICEF, in fact, now is talking about focusing on the 6 to 9 and the 6 to 10 age group. When you focus on the under 5, you're fundamentally focused on infectious diseases. And therefore, a lot of global child health has been dominated by that discourse. And I'll come back to that point later on. So when you separate out by age group, the top 20 causes of death, you see by high income categories, things that all of you see here in the US. Not only things related to the period of immediate birth, but also injuries and violence dominating the causes of death. In low-income countries, however, Sub-Saharan Africa, South Asia, there's still a very, very high dominance of infectious diseases. And I know many of you work in those situations. So the income stratification for global child health is incredibly important if you want to figure out what you're going to do. Similarly, for disability-adjusted life years, you see again a lot of NCDs, or non-communicable diseases, dominating high income as opposed to infectious diseases dominating low-income countries. Now, if we turn our attention to different age groups, as I've just demonstrated here again, if you look at the 0 to 4 age group, then again, a lot of infectious diseases. And that's why a lot of global health discourse. As you look at the last 5 years of childhood, you see how much injury, violence, and trauma play a role between the ages of 14 and 17 globally. This is global data. This isn't region specific. And then finally, our own country, the US. If you look at the difference between 1990 and 2017, you do notice again a reduction in child mortality across the ages, across this span of 3 decades nearly. And you see things creeping up, including substance abuse disorders that had previously never been the leading causes of death in this country. So even in our country, we are demonstrating changes over decades of time. And if you look at the top 20 causes of death by age group, you see the under 5, for those of you who do neonatal and early child, as opposed to, of course, the last 4 or 5 years. So there is distinction and division. And by the way, GBD does country-specific analysis. And this is downloaded data for US from GBD sources. Let's compare this to a low-income country like Pakistan. If you look at, again, the first 4 to 5 years of life, heavy domination, and just like the US, the last 4 or 5 years are NCDs. And that's been completely neglected and ignored in traditional child health, even though it's happening there. These kids are now suffering what we call the triple burden: infectious, non-communicable, and injury and trauma at the same time. So what this means is that, yes, the good news is we've had substantial reductions in overall child mortality, particularly in the control of infectious diseases. But what we are seeing is a transition to more morbidity, more disability, and more chronic diseases or non-communicable disorders. And this means that global child health has to pay attention to these. As a result of this, and in terms of reflecting on this, I think that global child health is facing a few challenges. And I'd like to take you through some of those challenges. I'll present 7 distinct challenges that I think are incredibly important for us in global child health. The first one I demonstrate by looking at now CDC data. So Rebecca Cunningham and colleagues took CDC data for 2016, looked at all causes of child death in this country and adjusted them for 100,000 children and adolescents. So the denominator is not the general population, but the population that is specific to your age group. And if you see there, according to their analysis, 60% of deaths occurring in children and adolescents are actually all injuries. If you then look at the trends in the leading causes of death, you see, in fact, things that are going up rather than going down. And many of those things going up are the ones that we are incredibly challenged by. So when people see this, they have what I call the first challenge, the normative challenge. They're like, we don't believe this. This couldn't be our state. It couldn't be my city. It couldn't be my country. And this I don't believe type of reaction is really, really important for us to confront. I am confronted by this when I talk around the world because people say this couldn't be true. So our normative understanding of the child health burden actually has to change. We have to keep up with the epidemiology, not what we were taught in medical school 20, 30, not 30 for me, still. I'm going to say 5 years ago, and many of your younger colleagues that I see in the audience. So that's our first challenge, right? A second thing is happening. So here's a classic thing that I encountered when I was working in Bangladesh. I worked in Bangladesh for nearly 20 years. Amazing control of infectious diseases. Bangladesh is a delta. It has large number of water bodies. And so what happened? As infectious diseases went down, thanks to public health and medicine, other things didn't. So now, between the ages of 1 and 4, nearly 45 to 50% of children die from drowning. Nobody had ever thought about drowning before. And this is not swimming pool drowning. This is not your backyard. These are lakes and rivers and ponds and ditches, right? This is a delta. And so this came as a huge surprise in the National Health Survey that happened there. And this reduction is both great for us to talk about the story of public health, but this part doesn't move and hasn't moved, and so is important for our research enterprise. Here in this country as well, if you look at this figure, which demonstrates both males and females between the ages of 0 and 19, and everything that's color-coded is color-coded by causes of death. And if you look at this, the largest years of life lived with disability in this case, I'm sorry, not death, but disability in this case, you see those purple and blues are all around chronic diseases, about mental health conditions, on substance abuse disorders. This is important. And then these are years of lived with disability in terms of diseases. If you flip this picture to risk factors, then you begin to see this huge blue area. It's all related to alcohol, tobacco, and drugs. That's the picture for years lived with disability. These are years of life which children live with different types of conditions, state less than perfect health, that don't cause mortality. And so our second challenge is a systemic challenge. I am proposing that our second challenge is because our delivery care systems are based on a different type of disease model. And therefore, we have to think about reframing, reorganizing, readjusting, and I'm sure the Children's National is possibly a leader in this. But I'd like to make sure that it is so. And so as we think about strengthening our health systems, both at city, state level, but also at national level, we have to think about these changing disease and risk factor burdens that are now imposing on our children. So that's the second challenge that, as I see it, for global child health. The third one, which I'm sure many of you are familiar with, this is a great slide that I've used in some of my lectures. It demonstrates the number of countries implementing an intervention, mostly in this case, as you can see, infectious disease interventions, years after it was discovered. So you see, in general, it takes decades before these interventions are getting to people. And if you think of Hep B, for example, Hep B vaccine, there are people out there in sub-Saharan Africa that need this vaccine that don't get it. And so this notion that just because we know something is available is actually going to reach those who are most in need is extremely difficult, particularly for global child health. So that's what I'm calling the capacity challenge. Who's going to deliver these interventions? Where are those health workers? Where have they been trained? How are we going to put the system together? So getting the right type of human and technical resources to actually implement these interventions is incredibly important. That's our third challenge for global child health, inclusive, obviously, of stuff done right here in this country. Now, this work is about 5 years old, but again, I haven't found a similar analysis more recently. If you know of one, please let me know. This looked at the pediatric disease burden around the world and also looked at the pediatric trials, largely heavily dominated by clinical trials, that are done by regions. In fact, 79% of all pediatric clinical trials were done in high-income countries. However, 73% of the entire disease burden of global child health is in low-income countries. That's not to say those trials shouldn't be done. That's not what we are saying. But what we are saying is that the research enterprise is falling short. It's shortchanging those individuals that are suffering this disease burden. And in a ideal world, there ought to be much more research being done in low and middle income countries. And so the fourth challenge, which for those of you who have a research bent, I'm sure are going to be sympathetic to, is a research challenge, right? How does research keep up with changing disease burdens, and how does it address and benefit those individuals who need it most? And in some ways, I feel academic centers like GW, like Children's National, have to take a lead in this. They have to show how we can do this better. Similarly, there are interventions that sometimes a doctor doesn't necessarily prescribe. And they've been out there for 50 years, and yet you find children that don't have access, that don't have availability. Less than 10% of children, according to my own work, wear seatbelts or helmets in vast regions of Africa and Asia. We've published that extensively. They've been out there for 50 years. This is ridiculous. And so I think there's a huge policy challenge here as well. The policy frameworks are not there to allow us to make these things happen. There are countries with no laws mandating child safety seats. If you don't have a law mandating that, nobody is even going to start implementing them. Having a law doesn't mean there's implementation either. So it's an important step, but it doesn't go all the way. And so I think there are implications for us as we think particularly of non-communicable diseases and particularly thinking outside the box. And when we talk about these conditions, when we look at, for example, the US and compare it in specific disease conditions that I've just highlighted, if you look at motor vehicle crashes, we are competing with Mongolia. If you look at firearm deaths, we are worse than many, many low and middle income countries. So I think it's time for us to also think about another challenge, which is what I'm calling the reach challenge. The traditional domains of child health have to expand, and I know many of you are already doing this. So this is not something new for you, but I want to make the point of working with other sectors, of making sure that sometimes you're not going to lead, you're going to follow. Sometimes you're only going to be part of the solution. You're not going to be able to implement the most important one. And so our responsibilities from the health sector will change over time, depending on the challenge, depending upon what we are confronting. After the kind introduction that Dr. Woodford gave for me, this last challenge will not come to you as a surprise, because when I see things like this, the disparity right here in this country, when I figure out that the child life expectancy in the Philippines can vary by 20 years within one single nation state, then I get really worried about our ethics. And so my last and final challenge is to challenge ourselves and to say, really, are we looking truly at social justice? Are we truly interested in social determinants of health? Are we actually also analyzing our responses from an ethics perspective? It's not just analyzing the problem from an ethics lens, but our response. Is our response appropriate? Is it contextually relevant? Is it culturally sensitive? And so on. So ladies and gentlemen, I've taken you through quite a bit of quick thinking, but I'm presenting to you these 7 challenges for all of us as a community. And if those of us who are online or if this is being live streamed, for those of us out there in the world to seriously think about how do we address this? How do we think about these challenges? Maybe my framing you disagree with. Maybe you don't like 2 of these challenges. That's okay. You've got plenty of challenges to work on. Define them and frame them yourself. But what we have to say is you can't accept the current status of global child health. You can't accept the current status of US child health. And if you're in that business, something should be making you very, very disturbed and move forward. Now, like I said, I don't like to leave people with just a description of problems. I'm going to give you some suggestions of solutions. Some of them I'm actually working on myself. Some of them I hope to work on with colleagues like Professor Shanti Amaratunga from New Zealand, who's visiting us and is gracing us with her presence today. The first one is maybe more from a global perspective than necessarily your perspective here at Children's, which is to redefine child health. I think this notion that child health is tuberculosis and malaria, and that's what we have to fight out there, is got to change. We have to encompass the true burden of disease that children are being afflicted by. We have to understand who's involved. We have to, in fact, look at not just mortality, but also disability and morbidity. And why? Because right here, if you look at the situation, again, the color coding I've explained to you, these are the percentage of deaths. If you look at the US, which is the topmost bar, you see a particular distribution of that color. But compare it to across this, you begin to recognize that child health also cannot be generalized everywhere. You have to understand the region-specific burden that you're addressing. And that's why it's incredibly important to think very carefully about this. And the World Health Organization this year has announced new targets. They are announcing this drive towards the triple billion target. They want 1 billion people in universal healthcare. They want 1 billion people protected from health emergencies, and they want 1 billion people enjoying better health and well-being. So from one perspective, this is great. This gives you all the material for the fight for public health, social justice, and treatment. On the other hand, how incredibly difficult are these to measure? How incredibly difficult is it going to be to actually make this happen? And these 1 billion people, some of them live in this country. don't think that this is just about low-income countries, right? So this is, I think, our pathways, our opportunities are here. So let's redefine children. Let's embrace these global challenges and say, how can we contribute to this 1 billion or triple billion, in this case, enterprise? I think the second thing that we have to think about, where I think you all play an incredibly important role, is thinking about new models of care. Obviously, we have to look after our acute conditions better. I saw a wonderful ambulance standing downstairs, and we have to think about emergency medical system and all types of acute care. But we have to think about chronic models of care. Years of life spent with repeated visits. What does that mean for our healthcare system? Not just in terms of availability of physicians, nurses, and healthcare professionals, the costs, the policies, the reach, the access. And very importantly, what and how do we define functional outcomes for such a system? Reductions in death are presumably concrete, still challenging to measure, but changes in functional outcomes often are extremely diversified and disease-specific. So very difficult to put together in a holistic fashion. So thinking about these new models of care becomes incredibly important for us, both in cities, but also in rural areas and in underserved and underprivileged populations. In fact, I show you now data from Pakistan, very similar to what we saw in the US. So increasingly what I'm finding is that this divergence in thinking about high-income country child health and low-income countries, yes, there are specificities, but there are also some points that we can talk about together. And that's incredibly important. Be open to learning from your colleagues in low-income countries, because maybe their models of care might give you ideas about your models of care here. The transfer of knowledge doesn't have to be unilateral. It ought not to be unilateral. It has to be bilateral if you're open to innovation and change. The World Health Organization is very concerned about quality of care too. In fact, this past 6 months, they've released a handbook. I'm not sure who reads these handbooks, but I wanted to make you aware about these handbooks. And this comes on top of 3 major publications in 2018 on quality, including the Lancet Commission and our own Institute of Medicine report, the National Academy of Sciences report. So, things that a lot of people are thinking, and we have to make sure that that gets implemented as part of the second pathway on quality of care. The third pathway that I'm going to suggest, and I know, Lisa, you would be interested in this, is instead of talking about child research or child health research, let's talk about research for child health. Now, that research could be any method, any topic, anything that influences the improvement of health and well-being of children. So we have to think about going beyond traditional boundaries, particularly in global child health. Our engineering colleagues, our urban design colleagues, our colleagues out there in law, justice, and other sectors, they may have incredibly important solutions for global child health. We just have to embrace them. It is incredibly important to do that. And I think research increasingly has to follow multiple outcomes, not single outcomes. I know we often drive our sample size formulas and our p-values by single outcomes, which is fine if you need to get that NIH grant. But once you have it, put other outcomes in between there. Get those additional resources to make sure that you can measure a little bit more while you're at it. Because I think that will mean incredibly important for us. And this is important because, particularly for us in the academic sector, we are responding not only to that diabetes or tuberculosis or malaria outcome, but we are also responsive to our social mission in academic centers. That is, we need to make sure that we are somehow also exploring pathways for access and reducing of inequities. And so the social mission should always influence our research mission as well. And the way you can do it is by building your research enterprise in a way that explores and disaggregates data and presents things that are conducive to and reward pathways towards achieving that. And I think all of us, Matt, including Children's and GW, should ask ourselves the question, how are we doing this? Are we doing it well? Are we really infusing our social mission with our research mission or not? I think another pathway that is incredibly important is sometimes we don't realize the impact of our own decision-making in global child health, and I think we should. We think that we have generated the evidence. It's published in New England Journal of Medicine and Lancet. How do we get that into the hands of policymakers, and do policymakers actually use it? several years ago, I interviewed policymakers from 6 low and middle income countries, and I said, do you even want to hear about evidence? Do you care about evidence? It was very interesting. The answers that I got, one of the earlier papers on the empirical evidence around this topic was, yes, but more yes when it suits me, extremely yes when it suits my vision of what I want to enunciate. So this selectivity and absorption of evidence is incredibly important. And what are the pathways for helping that? People are talking about the research to policy nexus in this country and in other countries as well, and how do you adjust that to dominate by facts, although we've learned here that facts are not facts. And it's a different conversation that we are having in this country. And my one way to demonstrate this is this. It's a picture from a handbook on road safety, so I apologize for those of you for talking a little bit more about injury prevention, which is close to my heart. But this, from your Hansen book, on the left you see road safety picture. And that's what we always see. You know, we've got to figure this out. We've got to make sure that things are safe. However, what Johansson said, if you look at the road this way, it changes your perspective. You begin to recognize speeding and protecting children from and vulnerable road users from others becomes different. So sometimes it's not that you're changing the world, it's changing how you're framing things. That really helps you communicate to that last mile and communicate at that policy level. So just by way of example, this changes our perspective certainly in the field of injury prevention. I think a fifth pathway that will be helpful for us is developing new partnerships. These partnerships, of course, can be within the health sector. GW and Children's Health are engaging and developing partnerships with other universities, but also outside the health sector. And I know you have partners outside the health sector, but very importantly, collaborations with lots of stakeholders out there, particularly those that complement your expertise, and also at the regional and global level. And I know that your Global Child Health Group is out there in various countries and communities and working on projects that are incredibly important. So I think using the power of partnership is really, really important for us. If you look at Global Child Health, and this is just my listing of all, and this is not even complete, imagine all of the agencies, the organizations, the universities, the NGOs, the private voluntary organizations, the community organizations that we need. The one very important thing that I've highlighted here is don't ever forget the community as a partner. That's a fundamental principle of public health. You work with people. You don't work for them, but you have to work with them. You have to understand that you will never do things to them without them, right? Those are important sayings that allow us to always never forget the community as an important stakeholder, and I know you all at Children's do this incredibly well. I think a sixth pathway forward is to talk about the governance of global child health. And this is multiple levels. Governance within institutions. How is Children's National governed? Are you optimizing your governance and policies for research and outcomes in child health? At the level of the country and nation states, how is global child health policies being considered? Is it actually part of child health? Is it part of child welfare? Is it nested in some other agency? Very importantly, I think that a state of global child health is in a little bit of a disarray right now, because there's a lot of reformulation happening at organizations like the World Health Organization, WHO and the UN, and that potentially has some risks for global child health. And we have to keep an eye out on that very, very carefully. In fact, our opportunity came a couple of years ago with the Sustainable Development Goals. And I'm sure you're familiar with them, but the 17 SDGs now are the framework for all UN health work, certainly. And SDG 3, the third one, is about healthy societies, good health and well-being. And if you look at SDG 3, for the past 2 or 3 years, and you ask yourself these questions that my friend Dr. Robert Martin asked, has global health governance changed because of SDGs? Not really. Has funding commitment changed? Not really. So we've got to watch out. We have an opportunity with SDGs. We talk about health and transport and life and welfare all across the board. So we are part of the UN mission. But at the same time, 2 to 3 years out, we aren't noticing the change that we were hoping for. So there's still a lot of work to be done, and I think we all can partner and work together for that. Finally, since I had 7 challenges, I have 7 pathways for solutions, emphasizing values. This is incredibly important to show how we value societies and what are our societal values. Context matters. When you work in Ward 7 and 8, how do you work in those wards? When you work in Uganda, what are your principles of working there? When you work in New Zealand, what are your principles of working in New Zealand? It is about health for all, period. There is no qualification. Everyone deserves health and the opportunity to be healthy. That's fundamental, right? The opportunity to be healthy. And ensuring that accessing this healthcare is fair and accessing the opportunity to be healthy is fair is incredibly important for us as well. These are important because at this point in time, like I mentioned, there are risks to global child health. In fact, for those of you who follow the literature on this and some of the movements, the WHO has announced a complete transformation last month starting from their headquarters in Geneva. They've completely redrawn the organogram. And as you redraw the organogram, some things lose and some things win. And unfortunately for us, there is risk that global child health might lose. What will it lose? A department, a position, a cluster, a unit. And if you don't have a department, a cluster, a unit, then sometimes budgets are not allocated appropriately. So there's resonance in everything here, right? It's not about always thinking micro, which I know you do every day, but once in a while, thinking about the macro implications for global health as well. In fact, my colleagues, Dr. Bhutta and Dr. Black is chair of global health at Johns Hopkins, and Dr. Bhutta is co-chair of the Center for Global Child Health in the Hospital for Sick Kids in Toronto, just published this 2 weeks ago, and this is what they said, that the World Health Organization reorganization for universal health coverage does not mention child or adolescent health. In fact, the restructuring and initiatives of WHO do not mention mothers or children or child health exclusively. So I think we are in the stage where if enough of us make a noise through your movements, through the literature, through your NGOs, through your professional societies, hopefully it will be heard to make sure that global child health remains strongly within the mission and vision of not only the WHO, but other UN agencies. So ladies and gentlemen, I've thrown quite a bit at you, but I only did that because I think you're extremely competent to absorb all of this. I shared with you my perspectives on 7 challenges, and I also therefore prescribed to you 7 pathways. They aren't solutions as much as pathways towards getting there. I hope that this has been stimulating, and I'm very happy to be told otherwise, and very happy to also hear about exceptions and your perspectives working from where you are. Thank you again for giving me this opportunity to come and speak today.
Before we take questions, on behalf of the Children's National, thank you very much for coming.
Thank you so much.
And keeping us up to this.
Yes, sir.
Wow, that was.
I can hear you.
That was really fabulous. Thank you for that, Dr. Hyder. You know, I've been reading some of the optimist literature. Are you familiar with this trend? And it's really an emerging literature. It says the world's really not as bad as we think it is, and there's a lot of very hopeful things happening around the world. And one of them is, the big themes is this incredible improvement in child health outcomes over the last 2 to 3 decades. And another one is this remarkable alleviation of poverty. Something like 200,000 people every day in the world emerge from extreme poverty. It's just incredible, the statistics. How interrelated do you think those phenomenon are? Specifically, can you have sustainable improvements in child health and child health outcomes without sustainable improvement in the socioeconomic status of families?
Look, great question. Thank you so much for asking me. And the way you ask it, I know how much you've read and are knowledgeable about it. Let me share 2 quick perspectives on that. My first perspective is the following. I think the improvement in child mortality and child health well-being could not have happened without the associated improvements that you're talking about in the context in reductions in poverty and in the daily lives of human beings that exist in those situations. However, when we think about from a health sector, what can we do to make things different? We have to be very careful about both our ability to act in those situations. So what are the interventions that we can actually successfully implement? And those things that as a global community we can help with. Poverty alleviation fundamentally driven by national resources, even though the development banks make it a huge priority for them to talk about poverty eradication. I think much of that has come through economic development and social development happening at the country level. And that has huge co-benefits for child health, adult health. But our capacity from the health sector must be to constantly talk about the intervention that we can help with in that context. And so we love the fact that there are co-benefits to health, but that still means we got to treat that strep pneumonia. We've got to get out there and treat that tuberculosis. We've got to make sure that insecticide-treated bed nets are available. And therefore, I don't see this as anything but complementary. I think, in fact, sometimes our claims of benefit, certainly in public health, are way higher attributed to our interventions when, in fact, it was substantively determined by economics. If you look at trends in things like motor vehicle rate and suicide death rates, they often mirror changes in economic development much more strongly than anything to do with interventions. So I am also an optimist after years of working in the developing world. I think fundamentally things will improve, but I'm also a firm believer that things will improve because the people living there will improve themselves, not because of external assistance by any stretch of the imagination. So, but thank you.
I'd like to second the thanks from Stephen. This was wonderful. I had a comment and a question. My comment was, I don't know if you're aware, but we have a separate program called Safe Kids International. Are you aware of that? And I was wondering, obviously they focus on non-intentional injury in children. And when you spoke about Bangladesh and drowning, it seemed to me that that would be an obvious thing. So my comment was, do you think there are additional ways that Safe Kids could work with you and your group to really move things forward? And my question was the broader one of thinking about the resources we have here and the incredible interest led by Craig Sable in global health. Are there things that off the top of your head you think that we could collaborate with you and your program on?
Thank you, and nothing like very specific questions of, okay, you are here, now tell us how you can work with us. Okay, but thank you, Mark. First, I've been a big fan since I met Marty Eichelberger many, many years ago, and he started Safe Kids. And now with Serene, in fact, I was at their offices 2 months ago exploring how we can work better. I've actually done evaluations of Safe Kids for them a few years ago. So I think their model is excellent. I love their work. I think in terms of efficacy, there are some gains to be had. And I think there are important issues around capacity development of Safe Kids model in the countries where many, many of these child injuries are happening. And I know they're aware of that, and they really want to partner. So, in fact, one of the things we're going to be talking to them is about some developing training programs together and training colleagues in low and middle income countries. The wonderful work that you all are doing, and I don't know everything that your group does, but I hope to meet with them and work together. I think what is fundamental is to sensitize the global child health community on chronic diseases. So I think non-communicable diseases is incredibly important, particularly from a risk factor-based approach. So thinking about how our children are being exposed to alcohol and sugar and tobacco is, I think, fundamental to the future growth of this disease burden. And I think we have to be a little brave because industry sometimes doesn't have exactly the same mission as we do. And so I would love to engage more with your global child health colleagues and say, how can we work together to make sure that our children around the world, and when I say our children, I just don't mean American children, I mean children of the world, are protected from those risk factors. And not from the framework of it's her or his choice. We all know that if you live in a neighborhood that only sells Coke, what will you drink? Coke, because it doesn't have any other option. So I think we understand the power of policy and legislation, and I'd love to work on those types of things with your group. But thank you, and we'll dialogue more obviously on that.
Excellent talk. That you are speaking my language for sure. I am part of the Global Health Initiative. I lead the education part of it all, and so capacity is what I'm most interested in. I know our mantra is we are trying to translate what we know into what works, exactly what you were talking about in terms of implementation. I come from Baylor, and I spent many years in sub-Saharan Africa, and essentially was working on sustainability in terms of HIV care. And I think now my next shift is a lot of my former colleagues and healthcare workers in sub-Saharan Africa, they now know what to do, but there's that QI component that you're talking about. Well, and right now, what I'm trying to work on is building a QI curriculum so that our residents, when they go abroad, can expand the bandwidth of their colleagues abroad. Since, here we hear about QI all the time. Abroad, obviously, they're worried about the kid that's dying in front of them of pneumonia, of diarrhea. What is your opinion in terms of models of QI curriculums that work abroad, or models of care in terms of public-private academic institutions when it's abroad and not necessarily in our own backyard?
First of all, thank you for being here, and thank you for all the work that you've done over the years, so congratulations. Two comments. One, I think the notion of quality improvement programs, particularly in low and middle income countries, is still a very hard sell. For about 10 years, I've been trying to promote quality improvement with respect to trauma registries, both for child injuries as well as for adult injuries, and it's been really, really challenging. Last Friday, thanks to an NIH grant, I didn't travel myself, but my colleagues went, and we released a traumatic brain injury guideline for Uganda at Makerere University and the Uganda Society for Surgeons. And I can tell you that in many, many instances, it's either peripheral to their practice or it's considered policing. So go 30 years ago and talk to some senior colleagues and say, when this started, when QI started, what did the first surgeons talk about? The first surgeon said, what do you mean? I know my outcomes are good. I don't need any data to tell me that my outcomes are good. And that's, I think, where we are. I'm not saying everywhere, I'm generalizing. So I think we have to be smarter about it. We have to think very carefully because of the lack of health insurance mechanisms there. Even funding and economics sometimes is not part of your rationale in thinking through it. But access is, and equity is. And so I think that conversation is still ongoing, and I welcome a dialogue with you to think about how we can do that better. But I can't help just adding one more thing. In thinking about, you said you used the word residents. In residents going to the developing world and spending time, I hope and I trust that you all have thought about that incredibly well, because this is one of the situations which gives huge benefits to the residents and sometimes not so much benefit to the people that they spent that 1 month, 2 months, 3 months with. So let's make sure that the old medical mission approach is completely destroyed and that we have a new approach of partnership in which they form part of a longer-term relationship in which they become human resources in achieving an aim rather than doing these mini little projects, which is to their benefit, and not making sure that it leaves something behind. So just a comment on that because it's important for me.
Yes, can I just say I'm very glad to say that Children's National is very good at the bilateral partnership, and we also have been hosting folks here. But thank you very much.
I think there's a question right there, and then Lisa, let me know when the time's up.
Yeah, we have a few more minutes.
Thank you very much for inspiring talk. I was curious about your thoughts on national information campaigns in the sense, and that sort of relates to Dr. Teach's point, in that parents are generally interested in doing what's right for their kids, regardless of where they are in the world. And the impact of having information available and then having the resources to implement it, such as seatbelts, car seats, helmets, has been one of the most successful public health approaches. What are your thoughts on national level approaches to information dissemination?
So I think great question. A couple of thoughts that I have on this. First, obviously the most widely studied model is national immunization days across the developing world. Very, very hard campaigns led by UNICEF. Blanketing, for example, for polio eradication. That's how many, many countries eventually achieved polio eradication, because national campaigns followed by health workers going out. Everybody's aware, everybody knows, and everybody participates, minus Nigeria, Afghanistan, Pakistan. Those three countries have been the biggest roadblocks. Social marketing campaigns, slightly different from national immunization campaigns, is social marketing strategies have found to be effective, scientifically speaking, usually cause change between 10 and 25% effectiveness ratios of any social marketing campaign for a public health product. I think the problem comes in the words, to use your words, in two levels. Number one, which is the difference between the campaign and the availability of the products that are accessible to individuals, right? And in the developing world, that's a big issue. So you can't campaign for, helmets when there are no helmets less than $100 on the market. Nobody's going to buy them. You just priced out everyone. Similarly for, go see your physician. Well, there aren't any physicians to see. Where do I go? I have only 50 rupees. I don't have $10 to pay for fee, etc. The second one is our ability to say, oh, the campaign's done, that's the end of my work, and not follow through with the delivery of real intervention. So most of these campaigns, and I'm a firm believer in effective use of communication, media, marketing strategies, but not alone. There is no marketing strategy that has ever reduced injury, for example, rates. It's because people use safety interventions that injury is reduced. So I think sometimes we think that just by informing parents, just like I know smoking is bad, but I continue to smoke, is enough. But the fact that you have legislation that forces me to quit it once I enter this building is incredibly important. So similar pathways, I think, for the future in the developing world.
Let me just ask a quick question from the perspective of organized clinical and translational research programs like the CTSA. I was struck by a couple of things that you said. Number one, I don't believe this is happening here, which I think is a really important mindset and requires attitudinal and cultural change. Number two, I love the construct of research for child health. And sort of thinking about both of them, we know what success looks like over the long term. It would be that we would reduce morbidity and mortality for all of these communicable and non-communicable disorders. But in the short term, to try to address that, I don't believe this is happening, sometimes showing data to say, well, but we're doing this, and here's the improvement, so that people embrace it. How do you think about, on a global level, measuring impact?
So that's an excellent question, and I can spend hours about it, but maybe just a few thoughts. One is that I think we have to think about monitoring and evaluation framework from a proper system perspective. So you start with inputs, you get into processes, you think about outputs, which are often, medium term, and then you think about outcomes that are the long-term things that you're trying to achieve. We don't always think about all those levels in a very, and I've described a very simple four-step system approach. So I think it's incredibly important to think about that. Number two, what you said, having data from your locality, from your context, from your country is most powerful. It is interesting. I have gone into countries, downloaded GBD data sets for their country, and said, by the way, that's what GBD says in your country. I actually don't believe it, do you? Can you show me your data to say that these guys in Seattle, they're wrong? Because otherwise, that's what the world believes happens in your country. And that changes the conversation. Most people will say, I didn't even know there was Cameroonian data at GBD. Of course. They do 194 member states of the US. You can download that. So I think that starts a conversation. So data is powerful to start the conversation. The third, and you've already alluded to this is successes, right? So success stories are important, but the success stories have to be framed properly. What I don't like are non-governmental organizations showing, I've done this little project, I've changed the world. No. You've done this project in one locality, talk about the locality success. It's in one ward, you've changed things, kudos to you. But don't say that I've changed Washington, D.C., because you haven't, right? So that fine line between those success stories and the claims that are made around it, I think are incredibly important. And the final thing I think is that we have to dialogue. I think we have to constantly be in the realm of communication. And now on social media and other places, you have to start this conversation. And if you don't, nobody's going to come to you to talk about it. Nobody's reading your paper in the Lancet anyway. So I think it is opportunities like what you offer at CTSA, where we can sit together. You are offering the platform for us to say, hey, how can I talk to the mayor? How can I go out and bring 5 mayors together to think about this? So this is a huge opportunity for us. So thank you, actually, for doing that for GW and the children.
Well, that's a wonderful note to end.